Welcome back. Today we're going deep on a question about how intense renal replacement therapy should be for patients with acute tubular necrosis. Also known as ATN.
Yeah.
You flagged a 2008 study in your notes, and it seems like it really got you thinking about this.
Yeah.
And we've got some sources here to kind of help us unpack it all.
Absolutely.
Yeah.
ATN is a really serious condition. The kidneys have these tiny filtering units called tubules.
Okay.
And when those get damaged, they can't do their job effectively. And it's often caused by things like low blood pressure, certain medications, or toxins.
And so when the kidneys aren't working properly, that's where RRT comes in, right?
Exactly.
It's like dialysis.
Right.
It steps in to filter the blood and remove those waste products that the kidneys normally would.
That's right.
Okay, so the 2008 study that you highlighted, it looks specifically at this question of RRT intensity.
That's right.
So whether giving patients more frequent or longer dialysis sessions, essentially like a more aggressive approach, does that actually lead to better outcomes for those with ATN?
That's exactly the question.
Okay. So before we jump into the specifics of that study, our sources provide a really, really great foundation on just how these kidneys work and the different types of RRT that are available.
Okay.
I mean, did you know that our kidneys can filter like a whopping 180 liters of fluid per day?
It's amazing.
But only about 1 to 2 liters actually leaves the body as urine.
Right. It's a remarkable system.
It's pretty amazing.
The kidneys are constantly working to maintain the body's internal balance, filtering waste products, regulating electrolytes, even producing hormones that control blood pressure and red blood cell production.
So how do they actually do it?
Well, the sources describe this really intricate network of nephrons, and each of those has its own tiny filter and tubule system. They're like these microscopic filtering factories working around the clock.
Wow.
Yeah.
That's wild. So then when something like ATN hits and it disrupts these delicate structures, I mean, the consequences can be pretty severe.
It can be very severe.
Okay.
Yeah.
And our sources mentioned a whole range of potential causes for ATN, from reduced blood flow during surgery to exposure to certain medications or toxins.
Right.
It's a good reminder of how interconnected all the systems in our body really are.
Absolutely. And speaking of connections, let's talk about those different types of RRT that you mentioned.
Okay.
The sources outline several approaches, each with its own pros and cons.
Okay, let's break them down.
Okay.
So first up, we have hemodialysis.
Yeah.
That's the most common type, right?
The most common, yeah.
Involves using a machine to filter the blood outside the body. And it's usually done a few times a week at a dialysis center.
That's right.
Okay. And then there's peritoneal dialysis, or PD, which uses the lining of the abdomen as a filter. And that's often done at home.
Right.
Gives patients a little more flexibility.
Yeah, more flexibility and control over their schedule.
Exactly.
Yeah.
And then our sources also talk about continuous renal replacement therapy.
Right.
Or CRRT.
CRRT.
And this one is typically used for critically ill patients who can't handle the rapid fluid shifts of traditional hemodialysis.
Exactly.
So CRT provides
a gentler, continuous form of dialysis.
A gentler form.
Often used in intensive care units.
Okay.
Yeah.
And with each of these RRT modalities, there's that question about how intense the treatment should be to maximize benefit but not increase risk. Right?
Yeah, exactly.
Which brings us back to that 2008 study that you mentioned.
Yeah.
It seems like a good place to start unpacking this whole debate about RRT intensity and ATN.
Absolutely. Let's dive into that study.
Okay. So that 2008 study, it really caught your eye. What was it about this particular research that made it stand out to you?
Well, like we were saying, there's always this question in medicine about finding the right balance. Is more always better?
Right.
Or can too much of a good thing actually be harmful?
Yeah.
And this study really tackled that question head on when it comes to RRT intensity in patients with ATN.
And it focused specifically on continuous renal replacement therapy.
Exactly, CRRT. They wanted to see if a more intensive CRRT regimen, meaning a higher volume of blood filtered per hour, would lead to better outcomes compared to a less intensive approach.
Okay, so how did they actually set up the study? Like, what did it look like?
They randomly assigned patients with ATN who needed CRRT to one of two groups.
Okay.
One group received a higher effluent flow rate, So meaning they had more blood filtered per hour.
Oh.
The other group received a standard, less intensive flow rate.
So like a head-to-head comparison.
Head-to-head.
Of two different CRT intensities.
Yeah.
Okay.
Yeah.
And what were they measuring to determine if one approach...
Three key things. The primary outcome they were interested in was survival at 90 days.
Okay.
They also looked at how quickly the patient's kidney function recovered, whether they needed long-term dialysis after being discharged from the hospital, and how long they stayed in the intensive care unit.
Wow. Sounded like a pretty comprehensive assessment.
It was.
And what did they find? Did the more intensive CRRT lead to better survival rates?
That's where it gets interesting.
Okay.
The study actually found no difference in survival rates between the two groups. More intense CRRT didn't seem to help patients live longer.
So maybe more isn't always better. At least not when it comes to CRT intensity.
That seems to be the takeaway from this particular study.
Yeah.
But there's always more to the story, right?
Of course, yeah. What other findings came out of the research?
Well, while the more intensive approach didn't improve survival, it did seem to have some positive effects. The patients who received the higher intensity CRRT had faster recovery of their kidney function.
Oh, interesting. So their kidneys bounce back quicker.
Exactly. And they were also less likely to need long-term dialysis after leaving the hospital.
Okay, so it's a bit of a mixed bag then?
Yeah.
More intense CRRT doesn't seem to affect survival.
Right.
But it might help with kidney recovery and reduce the need for ongoing dialysis.
Right.
That's a lot to consider.
It is, and it highlights the importance of carefully weighing those potential benefits against the potential risks of any treatment, even one that seems intuitively beneficial, like a more aggressive approach.
Yeah, so what kind of risks are associated with more intensive CRT?
Well, it often requires larger catheters.
Okay.
And those can increase the risk of bleeding and infection.
Right.
And because it involves filtering a larger volume of blood more quickly, it can also lead to more significant electrolyte imbalances and fluctuations in blood pressure. Right.
And those can be especially risky for critically ill patients who are already in a fragile state.
It sounds like finding that right balance is just key.
It is.
You mentioned earlier that there's always more to the story.
Yeah.
What are some of the limitations of this 2008 study?
Well, one limitation is the sample size.
Okay.
It wasn't a huge study, so it's possible that with a larger group of patients, we might see some different results.
Right.
Also, there could have been other factors influencing patient outcomes that weren't fully accounted for in the study.
Yeah, so more research is always needed.
Absolutely.
Okay.
And in fact, this study sparked a lot of further research into RRT intensity.
Oh, wow.
Yeah, it really pushed the field forward and got people thinking critically about how we approach this treatment.
So you mentioned that your sources highlighted some controversies or differing expert opinions related to this study. Can you tell me about those? Yeah, one of the main points of contention is whether the findings from this study, which focus specifically on CRT, can be applied to other types of RRT, like hemodialysis or peritoneal dialysis.
Okay.
Some experts argue that we need more research on those different modalities before making any sweeping conclusions about RRT intensity.
So we can't necessarily assume that what applies to CRT automatically applies to other forms of dialysis.
Right. And there's also debate about how best to individualize treatment.
Okay.
Some experts advocate for a more personalized approach, taking into account the patient's overall health, the severity of their ATN, and other individual factors.
It makes sense that there wouldn't be a one-size-fits-all approach.
Right.
Everyone's different.
Exactly.
And their treatment should reflect that.
That's right.
Okay.
And that's actually something that researchers are actively exploring, trying to identify biomarkers or other factors that could help predict which patients would benefit most from a more intensive RRT approach, and which patients might do just as well or even better with a less intensive strategy.
So it sounds like this is a very dynamic area of research.
It is.
With a lot of ongoing debate.
Absolutely.
And new discoveries happening all the time.
All the time.
Yeah, it's been really helpful to break down this study.
Yeah.
And kind of get a sense of all the nuances involved in this debate about RRT intensity.
Yeah.
It's clear that there's no easy answer, and more research is needed to guide those personalized treatment decisions.
Absolutely.
Now, I'm curious to shift gears a bit and explore those other RRT modalities that we touched on earlier.
Yeah.
I'd love to learn a bit more about how they work.
Sure.
And when they might be preferred over other approaches.
Okay. Let's dive into peritoneal dialysis first.
Okay.
It's a fascinating technique that takes advantage of the body's own membranes to filter waste products.
So tell me more about peritoneal dialysis.
Sure.
It uses the peritoneum, the lining of the abdomen, as a filter, right?
Exactly. It's a pretty amazing process.
Okay.
A catheter is surgically placed into the abdominal cavity, and through that catheter, a special solution called dialysate is infused.
So the dialysate is what actually does the filtering.
That's right. The peritoneum acts like a semi-permeable membrane, allowing waste products and excess fluid to move from the bloodstream into the dialysate.
So the dialysate is kind of like a cleansing bath for the blood.
That's a great way to think about it.
Okay.
The dialysate sits in the abdominal cavity for a few hours, drawing out those toxins.
Yeah.
And then it's drained out, taking the waste products with it.
Okay.
And then the process is repeated several times a day.
And one of the big advantages of peritoneal dialysis is that patients can often do it at home, right?
Exactly. This gives them a lot more flexibility and control over their treatment schedule. They don't have to travel to a dialysis center multiple times a week.
Right. That's a huge benefit.
Yeah.
Are there any downsides to peritoneal dialysis?
Well, like any medical procedure, there are potential risks and drawbacks.
Sure.
One of the main concerns with peritoneal dialysis is the risk of infection. Having a catheter permanently in place provides a pathway for bacteria to enter the body.
Right.
So careful infection control measures are essential.
That makes sense.
Yeah.
Are there any other situations where peritoneal dialysis might not be a good fit?
It might not be suitable for people with certain abdominal conditions, like extensive adhesions from previous surgeries, and for people who are very frail or have difficulty handling the exchange process, it might not be the best option.
Right. So it sounds like choosing the right type of RRT really depends on the individual patient.
Absolutely.
And their circumstances.
It's a decision that should be made in consultation with a nephrologist and the patient's care team.
Well, this deep dive has been incredibly enlightening.
It is.
You've covered so much, from the basics of kidney function and acute tubular necrosis to the intricacies of these different renal replacement therapies and this ongoing debate about treatment intensity.
Right.
It's been a lot, but it's been really interesting.
A lot to unpack.
Yeah. So as we wrap up, I just want to leave our listeners with one final thought to ponder. We've talked a lot about questioning assumptions and challenging conventional wisdom. And in a field as complex and ever-changing as medicine, being open to new ideas and different perspectives is so essential. So keep asking those questions, stay curious, and never stop learning.